The other point is that the decision, the first meeting of OHTAC we ever had was the most embarrassing meeting for everyone who attended the meeting. Because we presented evidence and no one around the table knew how to make a decision. And we're talking about CEOs of, $1 billion hospital corporations, and they didn't know how to make a decision. Didn't know what to do with the evidence. So we constructed what we call the decision determinants, 4 major components: the evidence of overall clinical benefit and safety, consistency with societal and ethical values, value for money, which is the economic analysis, usually a cost utility, and the feasibility of adoption in the health system. And every time a decision is made, they will check each one of these and go through the process and go through the discussion until they feel satisfied that they've addressed each one of those components, and then make a decision. So it's not just about evidence. I stopped this slide in 2007 because I couldn't fit anything more onto it, but these are the single technologies that we looked at. So we'll start at in 2004, and I'm going to work my way through this whole number. But we've done about 130 individual technologies. We've got traction on 85% in terms of policy, some kind of traction in terms of policy. And when we started presenting these to senior management and Ministry of Health, assistant deputy ministers and the deputy and all that sort of stuff, I began to see the kind of glazed look going over their eyes. They're not interested in implantable cardiac defibrillators and drug-eluting systems. Show them that it's a rationalized way of diffusion. They're interested in macro stuff. They want to know, tell us how we're going to deal with diabetes. Tell us how we're going to deal with heart failure. Tell us how we're going to deal with these chronic obstructive pulmonary disease. We into the kind of macro picture, the senior policy decision level. So we developed the capacity for what we call mega-analysis. We take a disease state, a disease condition, you just aggregate it according to the main drivers involved in that disease condition. You just aggregate all the technologies around each driver, and then we re-aggregate those technologies according to evidence and economic modeling. And you can then say at the end of it, this is where you're going to get the biggest bang for your buck. Now, I'm putting this up because I want you to think about genomics. And I want you to, so maybe you should be cognizant of the fact that there is no such thing anymore as an isolated technology or as an isolated component of healthcare decision making. These are some of the mega-analyses we've done today. Cardiac morbidity, aging in the community, which is a real treat. Colon cancer screening, diabetes, intermediate care, wound care, cardiac diagnostic tests, chronic obstructive pulmonary disease. And we're now doing one on optimized chronic disease management, which is our mega tetra analysis. And these take us about 10 months to do with economic modeling. And I can't emphasize enough the importance of economic modeling with experts that we have at PATH, which is at McMaster. We provide course support to them. And at Theta, which is at the University of Toronto, also get course support. And they built these big microeconomic models where you plug any probability in and just spread out, 48 hours, 40-year time horizon data on avoided downstream events avoided and downstream costs avoided. I'm going to give you one example of that just to show you what it's about. Leicester, the Ministry of Health comes to us and says, we're about to announce a diabetes strategy. Can you give us evidence-based analysis on our strategy? So they're all lined up there with money to dole out, and they said, before we go public, can you do an evidence-based analysis for us? So these are the 4 major components they had in their strategy. They had multidisciplinary programs, insulin pumps for type 2 diabetes, patients on insulin obviously, behavior modification, and bariatric surgery. So we did the full-blown systematic review, which took us about 8 months. And then we took all the probabilities for each one of these and we plugged them into an existing economic model that we had, which is Ontario specific. Within 48 hours, we had this slide in our hands. This is a real credit to not just the clinical epidemiology methodology, but to the health economists and how the two come together. So let's look at the slide. I want you to look at the 4th line down. For those of you who don't understand this, the cost utility of dollars per quality adjusted life years gained is used a lot in drugs. So a threshold of anything more than, say, $60,000, $70,000, $80,000 per quality is regarded as increasingly cost ineffective. Anything below that is cost effective. So here's the economic model telling us what the cost-effective ratio is. The single most important cost-effective component of this strategy was bariatric surgery. It actually cured diabetes. I mean, I didn't know that. 75% cure rates for morbidly obese people with diabetes are cured with bariatric surgery. And if you look below that, you see, you scan over to the right side of the screen, you'll see events avoided: heart failure, stroke, amputation, blindness, renal failure, etc. Gives you an idea of the numbers. But it's the single most important cost-effective strategy. Next is multidisciplinary programs of nurses, dietitians, physicians, which is about $20,000 per quality. Then comes behavior modification. And finally, they were just about to launch this. Insulin infusion pumps for type 2 diabetes, $1.9 million per quality. Now, you don't have to be a health economist to understand that, or a mathematician. And they did not announce insulin infusion pumps. They put $120 million into bariatric surgery, and they're putting $70 million into the multidisciplinary programs. So field evaluation studies, which, for some reason, we seem to have taken the lead. We didn't mean to do that. That's the real Canadian way of presenting the stuff internationally. We're terribly sorry we didn't need to be successful with this, but what can you tell you? It's just the way it is. And we apologize. But coverage and evidence development is where you make a policy decision where you say, I'm going to let this technology go, but I'm going to pay for it only as long as you come back to me and you show me the evidence that you've collected during the time when we put money on the table. And then we have a right to revise what to put on the table for that technology. So for some reason, we've done more of these than anyone else, and since 2003. We being a collaboration consisting of about 5 different academic centers, including Mass. So I'm not going to take you through each one of these. I'm going to take you through one, drug-eluting stents. So in 2004, I think it was, 2002. End of 2002, 2 articles appeared in the New England Journal of Medicine that drug-eluting stents for coronary artery disease gives you a 7% restenosis rate for low-risk patients compared with the classical kind of standard bare metal stents, which give you 23%. So it's 7% for drug-eluting stents restenosis, 23% for the standard stent. And we decided that we were ready for this. We decided that we were going to put $12 million on the table for 3 consecutive years, tell the cardiologists they could use whatever stent they wanted, only if they put the patients on a registry where we could look at the outcomes, which they did. In over 18 months, we collected data on 23,000 patients prospectively with patient outcomes. Cost us about $500,000 to do this. And we found at the end of that, we were able to do what's called propensity score matching, 2 groups equally matched. And the outcome was this, that for low-risk patients, the New England Journal randomized controlled trials were bang on 7% restenosis rate at 1 year. Absolutely bang on. For the bare metal stents, the other older stents, the restenosis rates were meant to be 23%. They were 7%. For high-risk patients, it made a bit of a difference, and we funded drug-eluting stents according to high-risk patients. The beauty is, the data was owned by the leading cardiologists in the province. We had no argument in this at all. Conversion rate from bare metal to drug-eluting stents in Ontario, 30%, and in the United States, 95%. Cost effectiveness for using drug-eluting stents in low-risk patients, $2.2 million per quality. Now, anyone who tells me you can't afford to set up shop to look at evidence needs their head examined. Look at PET scanning. The whole world was on our case. We had egg on our face. We were called all the names in the world because we refused to adopt PET scanning without an evaluation of its clinical utility. And now the results are coming out of all these huge studies that have been run out of our coverage and evidence development program. And look at it. If you've got lung cancer, go get yourself a PET scan. It's terrific technology, and you shouldn't hesitate for a second. If you've got head and neck cancer, don't touch it, because you're going to get the wrong clinical decision made. And this is published data now out of Mark Levin's group, that's Ontario Clinical Oncology Group, which we sponsored. If you've got breast cancer, think twice. And if you're doing a PET scan to see whether you should have a metastasis resected from your liver, from colon cancer, you're not going to add very much by doing a PET scan versus a CT scan. So again, our uptake of PET has been slow, but methodical. It's looked at clinical utility, and it's an expanding program. It's the way we're doing things. So if you look at some of the technologies where we're able to do economic analysis, we have so far, in some of these major technologies, our cost saving to the Ontario health system is running at about $650 million. If you apply evidence, which is in blue, compared to if you hadn't applied evidence, which is in purple. So again, anyone who tells me they can't afford to put this stuff in place needs their head examined. So I'm now going to go to the second port of call. The second port of call is I'm going to try and apply what I've just presented and try and show you how this relates to personalized medicine. So when Brad called me and said, can you do a little blurb on personalized medicine, I did what any other evidence-based person does. I asked the question, what is personalized medicine? Because we're very inquisitive people. And I thought it would be a slam dunk. So I went to that great medical source, the New England Journal of Google, and this is what I came up with. A medical model proposing the customization of healthcare with all decisions and practices being tailored to the individual patient by use of genetic or other information. That's a great source of information, Wikipedia. And I thought, really? Or other information? I mean, isn't that what I've been doing for 35 years of my clinical career? The second definition, the use of all kinds of clinical and molecular information to optimize treatment and health outcomes for individual patients. Personalized medicine aims to answer precisely who should be treated and how should we treat them. Institute, this is Ginsberg Institute for Genome Sciences and Policy at Duke. Again, I thought to myself, there's something strange about this, because this is something, again, I think I do this when I'm sitting in a room with a patient, that I apply all that stuff. Personalized medicine, it kind of goes on. And some of them say that it's only genomics, some of them say it's anything goes, it doesn't matter as long as you're weighing up everything in the interest of the patient. I'm not going to labor the point, but I think it is really important that if you want to get traction on personalized medicine, define what that is and what you're talking about. Because other people are going to do it for you and they won't know what they define. So I went to, there's a journal called Personalized Medicine, and this is the aims and scope of what they have for personalized medicine. And it really is soup to nuts. I'm not going to read this out for you. I think you can see it from where you are. But it's almost anything that anyone does in genomics and beyond genomics. And I didn't find it particularly helpful in helping me in terms of policy decision making and whether we should be prioritizing anything that comes out of what's called personalized medicine. Targeted drugs and targeted interventions and diagnostics, I understand. So I want to just briefly, I want to have a little bit of fun with you. And I want to take you through some of the developments in terms of, well, Joseph, he'll probably know all this stuff back in his hand, but I want to take you through some examples of the development of cancer drugs since 1940, whatever. Because I think it's a real interesting story in terms of personalized versus serendipitous developments in terms of these drugs.